skills today and so let's talk about the areas that are spastic again. Okay, for the upper extremity, the scapula is retracted and downwardly rotated. The shoulder is adducted, internally rotated, and depressed. Elbow is flexed, arm is pronated, wrist is flexed and adducted, and the fingers are flexed, and the thumb is adducted across the palm. How would we position that person in supine? Right, you want to actually take them out of that position.
Oh, yeah.
So let's get a person and actually lie them down next to
Upper
them.
shirt sideline.
She said in supine.
Oh. This is a test
Then she
question.
said, but how in supine?
I don't remember.
So we can get some pillows. There we go.
Oh, it hurts.
Yeah, don't you do it? Doesn't it make you cramp?
Yeah, it hurts like kind of bad. I'm just gonna do it for instructional purposes.
There you go. Okay. So let's deal with even his head is tilted. Wrong way, but okay. What are we gonna do with the slide over just a hair?
Oh, whoa, whoa, watch.
See? The bucket of pretzels! My God! What are we going to do with this upper extremity? Let's get a pillow.
Grab the pillow down.
You're gonna lay that.
You put it in between his arm? Put the pillow like in between his arm and his thorax?
Well, it might not stay that way. Let's assume that he did that. Otherwise, he's a brain injury patient.
Thanks, patient.
And we probably do want his arm extended. Sit on it. All nice.
The rope.
You know,
Need another pillow?
so sometimes if you have someone that has a lot of tone, you want to start proximal to distal. So, thank you. So, let's say he has a lot of shoulder retraction. So we want to protract. So we're going to pull him out and protract him. And if he can't stay there, we're going to put a pillow or a towel on here. Probably a towel roll would be enough. Somebody grab a towel roll. So we're going to just hold him. We're going to pull him into the opposite direction. So we're going to do a low load, long duration stretch on the rhomboids. And kind of get them to relax. There he is. What a fine looking hole that is. Okay? And then, sometimes that's enough to, which I've had him slide over more. Sometimes that's enough to start to relax. I want to get the arm as straight as possible. And then I want the hand kind of supported. You know, to be honest with you, in that sense, if you can control the tone up here, this should calm down. But this is not necessarily a comfortable way to lie down. So at this point, I would rather splint the hand, put a splint on it, or something to open it up and just leave it in this position. Because in actuality, we're going to learn this later. Just like everything, relax.
I had a sound on.
It wasn't rigid. Like everything is gray. There's no black and white. And later in the book, it actually says the arm is supinated, not pronated. So the supination pronation part is not as strong, and I don't worry about that. More the biceps or the elbow flexion extension, the retraction and depression of the shoulder. Okay. So if you get him in this position and you get his fingers opened up nicely and you're supporting him, and again, there are actual, and I should ask the OTs if they have this. They have this kind of like our foam triangular pad. They have one that holds the arm. It has like a trough, and then it has something that separates the fingers, which you can actually put them on, and it kind of holds their arm you don't want to do this because that's encouraging that tone. So you want the arm kind of out to the side somewhat. Of course, in a wider bed. Okay, so that would be upper extremity position. So slightly abducted, scapula protracted, okay, elbow extended, wrist in a neutral position, okay, and the fingers in the hand. A way that you can reduce the tone if you're having trouble is to kind of grab in the hand and you kind of abduct the thumb, and by bringing the thumb out, a lot of times it will reduce the tone in the hand and then you can position. So keeping the thumb out to the side can be important, and there are actual cones and stuff that they can put that you can kind of put in the hand that kind of opens up the hand a little bit, keeps the hand in a more functional position. Wrap it like that. Okay. Keeps the thumb kind of out to the side. All right. So any questions on the upper extremity? If the head is involved, then you want to make sure that you're getting the head in neutral. Don't leave the head kind of pulled to one side either.
Is the towel roll on the scapula itself?
I have it under.
Is this the position that you would just like leave them in after you're done treating them?
Yep.
So with like the low load, long duration stretch, how long is the longest time for you to stay there?
Well, they should be repositioned. If you have someone that can't move themselves, anyone that can't reposition themselves should be every 2 hours. So, any questions on the upper extremity? Okay. Lower extremity. I'm going to take your arm out of here so that we have enough pillow. Now, what is this? The pelvis is retracted, which means hiked up, right? So, and it's actually kind of pulled back a little bit too. But, so, what you really want to
Can't do it.
yeah, don't. You're going to really cramp yourself. and that will be calling 911, and I don't want to do that. So you want to kind of bring it down. If the pelvis is very far retracted, which means pulled back, if you're seeing that this pelvis is really rotating back, then you may need to put a towel roll, there it is, underneath that pelvis to bring it forward and level them out a little bit. Okay? Because any sensory experience, so just kind of put it aside, so anything, and then just level them out. That way. Okay, so if it's really pulled back, you want to kind of level out the pelvis. Okay. Lower extremity, the quad can be spastic and it will force the knee straight. So this is the person that you can put something under to break up that tone a little bit and have the knee bend slightly, or even more. Skinny pillow. In this, you also want to keep the leg from adducting and then rotating in either direction. Sometimes they'll be flaccid and they'll actually roll out like 90 degrees. So you want to prevent that too. And you can do that with your towel roll that you steal from under the pelvis. Just by kind of pushing it up against the leg to keep it neutral. So the rotation, you just want neutral. Okay. As far as the heel is concerned, the same principle applies with keeping the heel off the bed. And there are special boots, POTUS, multi-purpose POTUS boots, that you can get, there's a picture in your book, that you can put on the person's foot that will keep them in neutral position of the foot and also keep the heel suspended inside the boot. Okay, another way of doing it, boots are kind of, these pillows are like so small. Kind of suspend so that the knee is supported and the heel is kind of off. The lower extremity is pretty easy. Make sense? I think I have a handout somewhere on positioning. We're going to do this again. God, how many times? We're going to do one more time when we do strokes. Okay, and that's when I'll give you that handout. So this is just one there. Okay? What about if I want to lie them, knowing those same spastic patterns? What if I want to lie him on his uninvolved side? How can I position his right upper extremity to kind of achieve the same thing? So when I'm on his left.
Leg on adducted, definitely want a pillow in between.
Okay.
Another pillow on the arm.
So sometimes you'll actually see kind of like, and obviously bigger pillows. So that he's not internally rotating. He's still internally rotating.
there we go.
His pillows suck. Okay, so the knee is flexed, the hip is flexed. Okay, so we're pulling the pelvis forward. You want to keep the foot from resting on the other leg. Hopefully you have a more neutral position. And again, if the foot is plantar flexing, you can use the multi-purpose POTUS boot to kind of hold, keep body parts off of it. So that's the lower extremity. Lower extremity is easy. What about the upper extremity?
Put a pillow underneath his arm. It's not adducted.
So usually you want to, I'm going to take these pillows out so you can make your legs comfortable wherever you want. Again, you want the arm kind of in neutral. You don't want it adducted across the chest. You want it kind of in neutral. Protract it a little bit, and then the arm is supported. As straight as possible, though this isn't necessarily as comfortable as this. As long as it's not bent like this. And then, of course, the fingers supported. She's going to write on them. She's writing on it. That's a lot. Okay? And then again, enough support so his head isn't doing that. So his head is neutral. All right, what if this is, what if he's going on his involved side? And we want to put him on his involved side because the sensory experience is important. If you take away some sensory experience from him, his motor response is going to be abnormal. So you can't do that. You have to have him experience that. Okay? So now he's on his involved side. I'm sorry. No, you're just, no, you're good. You're good.
This is actually kind of comfy now.
You kind of want to reach under and bring the shoulder forward. Okay, so that you're protracting. And then you kind of, this is the easy part, you kind of bring his arm out and support it. So that the hand is supporting a little bit of neutral. It's kind of springy. Okay, so protracting the shoulder, again, a position of comfort for his upper extremity. Lower extremity, now remember this is his involved side. So again, you really just kind of want the legs separated. And you can actually, one of the pictures that I give you, or hand out, so I give you that shows it picture, will actually take the lower extremity and kind of bring it into back into neutral. So you're just kind of like that. Now I find that asymmetrical positioning, so that one is flexed, one is extended, a little uncomfortable. So I'm not adverse to just keeping the legs like this, because I think that's comfortable. Now, if you have somebody that also happened to have had hip surgery, or has sensitivity over their great trochanter, then you're going to kind of have to modify it, like Dr. Tino said, and have them kind of roll back off of it so they get off of the trochanter. Okay. So basically, you just move opposite the spastic area in the opposite direction and support it there. And this is positioning that you would use when you were done with someone. And you train the family how to do it. You train the patient how to do it. You'd be surprised in hospitals and other settings that the nursing staff does not know. And it's not a neglectful thing. That's not their specialty. That's your specialty. So you have to teach, this is a better way to position it, as opposed to what you were doing. Well, don't say it like that. As opposed to crap you were using. Okay? So, again, you educate the patient and the family, appropriate positioning, and it has to be multiple positions, because nobody just lays in one position. That's another thing that happens to these people, they're always in the same position. Always, always, always. And that's not a good sensory experience either. What if they're sitting in a wheelchair? We kind of talked about this on that review day. So you just, again, you're supporting people in neutral. Okay. Bring the arm kind of out to the side, rotate it, and there, again, you can use a hemi tray. You all know what a hemi tray is?
No.
Hemi tray, I gotta order one. A hemi tray, you know what a tray is, right? That goes on a wheelchair. It's a full, kind of like this table piece down here underneath the table, the powder board, except it has two pieces that slide on the armrests, and so the person can put their hand on. So they can eat if they're wheelchair bound. They can eat off of this thing if they can't get onto a table, or if they're in front of the TV, it supports their arms. But you can have a hemi tray. So it just takes a cutout. It cuts it in half, so there's only a tray part on the side where the upper extremity is compared. You can there are actually hemi trays that have built-in splints on them. Autobox is one of the companies that makes them, and you can position the arm in a way that has finger spacers that positions the hand into a functional position and supports the arm right on the tray, so that their arm isn't falling off, and they're always being in place in a position that is good for their tone, helps moderate it, and keeps the hand in a functional position, because otherwise they get locked up like this. And then they'll never get back any function if they're spastic in this kind of position, becomes attractive. Okay, so again, keep them in neutral, you want the head supported. The wheelchair fitting is exactly the same as far as where the back has to hit, how long the seat depth needs to be. You just want them to be positioned in neutral and as much support on the back of the thigh as possible. So the positioning is the same, except you may need a hemi tray and try and keep their pelvis. What happens with spastic patients is they tend to kind of end up kind of like this. So you want to make sure that they're not slinging in the wheelchair. So the way to do that is to put a firm seat pan in it, a hard seat pan. So that allows them to sit up straight so they're not sinking into the sling in the middle. Okay? Any questions on position? Okay. Thank you.
Thank you.